So hello friends, let's start with the part 2 of the ENT. Part 2. Now we will cover all the ENT remaining topics. So let's start with tonsillitis. First see the question. A 10-year-old child present with a throat pain, fever and ear pain. He is diagnosed with recurrent tonsillitis. Which nerve is responsible for the ear pain in this pain? Since it is recurrent tonsillitis and tonsillitis will cause pain in the ear pain will occur. It is occurred due to the glossopharyngeal nerve and its tympanic branch. So we have to remember this fact. Referred ear pain in tonsillitis occurred due to glossopharyngeal nerve. The palatine tonsil receives the sensory innervation mainly from which nerve? The palatine tonsil receives innervation from the glossopharyngeal nerve, and that's why when it is inflamed, it impinges the nerve and causes the referred pain to the ear. The tympanic branch of glossopharyngeal nerve is also called as Jacobson's nerve. Can you tell the location of Jacobson's nerve? Jacobson's nerve can be located in the, we can see this is the middle ear cavity. This is superior bole, this is the inferior bole. It is present in the inferior bole with and along with internal jugular vein. It present as Jacobson's nerve, and it also is a sensory supply to the middle ear. Which nerve lies closest to tonsillar bed is risk of injury? Glossopharyngeal nerve. So it is embedded in it. Injury to glossopharyngeal nerve during tonsillectomy may have caused loss of which part of tongue? Important. We have discussed in previous. We have discussed this in the previous part. Like anterior 2/3 is from the coda tympani and posterior 1/3 is from the glossopharyngeal, and therefore posterior 1/3 will be of tongue, and palate will be through vagus. Palate will also contain some of the taste sensation, which will be through vagus nerve. Next, let's see a question. Let's pick up the pointers. A 55-year-old male patient present with the hoarseness of voice and difficulty in swelling. The patient was diagnosed with a laryngeal carcinoma. Surgical management was done. The post-operative image of which of the following surgery was done? Since we do not have any post-operative image, I think the image will be like this. This is the person. A hole will be made in the neck. So a hole will be made in the neck suggests of total laryngectomy, that is clearance of all the parts. After total laryngectomy, the permanent opening is created in the neck is for the bleeding. It's called a tracheostomy. We call it tracheostomy. It helps in the aids in the bleeding. In total laryngectomy, which structure is completely removed? Larynx is completely removed, along with its all the cartilages. After total laryngectomy, the patient usually speak using which voice rehabilitation method. Since like this, this is the trachea. This can be trachea. This is esophagus. Behind it is esophagus. So we create an opening between the esophagus and trachea. And this is known as a tracheoesophageal speech. Esophageal speech. It is called tracheoesophageal speech. Alternately, we can also use alternate method is electrolarynx can also be used. Electrolarynx, and here the larynx muscle vibrations are picked and transferred. It results in robot-like voice. Okay. The most common site of laryngeal carcinoma is which part of the larynx? So the most important part is the glottis. Like this, we have the part. This can be the glottis. It is the most common involved in the laryngeal carcinoma. Next, Rinus test. A patient, let's see the question. A female patient with a hearing loss is examined to have found with a Rinus negative at 256 and 5112, while Rinus positive at 1024. What is the air conduction gap? Let's see the basics. We have three tuning of 256, 512 and 1024 or 1024 hertz. So we can expect the negative for all, negative for both, like this. Since it's only one negative, the hearing loss will be less. The hearing loss here will be less, around 32 45. Here we have 45 to 50 decibel, and in all three negative we have 60 decibel loss, around 60 decibel loss. So answer came to be A answer. In Rinne's test, which of the following show and Rinne's findings are AC more than BC and BC more than AC. BC is the bone conduction, AC is the air conduction. If AC is more than BC, it can be normal, it can be SNHL. If BC is more, it can be conductive, it can be severe SNHL also. So the BC more than AC, it can be conductive plus it can be severe SNHL also. In Rinne's test, which type of hearing loss show AC more than BC, or normal or sensory hearing loss? In Weber test, sound lateralized to the Weber is like this. If the sound is lateralized to better or worse side, if sound to worse side, it is CHL. It better side is then it is SNHL. If it lateralized to which ear in the conductive hearing loss, in conductive hearing loss, it is the worst side affected ear. What is the typical airborne gap seen in otosclerosis? Same is the question, 30 to 45 decibel. And in Cahart notch in audiogram is seen in otosclerosis. It is a sudden dip at 2000 Hz. Sudden dip can also found at 4000 Hz. Important, sudden dip at 4000 Hz it's called as boiler's dip, seen in the noise induced hearing loss. Okay, noise induced hearing loss. Next, CL hearings again. Which of the following stand can be used? Let's mark the question. So we have this glottis, which is the most important part. Which of the following stain can be used for laryngeal mass if seen in electroscopic staining? It is a supravital stain which help in distinguishing. Which stain is used for vital staining? It is a supravital stain. It is toluidine blue, also called toluidine blue. Toluidine blue staining of laryngeal mucosa is mainly used to detect pre-malignant and malignant lesions both. Which stain is classically used to demonstrate amylodeposition? Congo red. We have read the Congo red, apple green bifringence. Apple green bifringence is seen in case of amyloidosis. Okay, amyloidosis. Which histopathological stain is routinely used to confirm the diagnosis of the carcinoma? It is a hemotoxic H&E staining. Routinely we use H&E staining for the diagnosing, and supravital stain is used for the pre-malignant and malignant characterization. During a microlaryngoscopy, a suspicious lesion is painted with a toluidine blue. What is the principle behind it? The principle is that whenever there is dysplasia, the nucleus cytoplasm synchrony changes, and it leads to increased content, and by C ratio is increased, and hence binding with dye increases. It's the basic of the dysplastic cells. Okay, next is juvenile nasopharyngeal angiofibroma. Let's see the question. 18-year-old boy, male, presented in the emergency department with the epistaxis is present. What is the investigational choice? CECT, PNS and MRI are given. What will we do? Always consider biopsy is not considered. Biopsy is not taken because of the can lead to epistaxis. The best answer is CECT, PNS and no sinus. And it also male present with a recurrent epistaxis and nasal obstruction with a nasopharyngeal mass. What is the most likely diagnosis? It is juvenile nasal angiofibroma. Next, what is it investigational choice for the suspected nasopharyngeal angiofibroma? And we have read a CECT of the paranasal sinus. Which radiological sign is classically seen in juvenile nasal angiofibroma? Since the juvenile nasal angiofibroma grow like this behind the nose, then it causes the anterior bowing of the posterior maxillary wall, and it is known as antral sign or Holman-Miller sign. Okay, it is the anterior bowing of the posterior maxillary wall. What is the common site of origin of juvenile nasopharyngeal sphenopalatine? We have read it before. What is the most important pre-operative procedure done before the JNA? First we will do embolization because it carries a risk of bleeding. Then we will conduct biopsy. Okay. Next, a female singer presents with the hoarseness of voice and difficulty in singing at high pitch. On laryngoscopy, it was noted one vocal cord is bowed and position lower than the other, and is associated with muscle tone is shorter. But the muscle is likely affected, since the main tensor of the larynx is cricothyroid. Cricothyroid is the main tensor. It can be the answer. Cricothyroid is the answer. Cricothyroid is supplied by the external branch of the superior laryngeal nerve. We have read it before. So cricothyroid muscle, which are external branch of superior laryngeal nerve. Injury to external laryngeal lead to inability to produce high pitched sound. We can do and this type of operation is type 4 thyroplasty is done, which leads to tightening of the muscles. Tightening of the muscle is done. The posterior, which of the following the only abductor, it is posterior cricoarytenoid is the abductor. Only abductor it is supplied by the recurrent laryngeal nerve. Which muscle adducts the vocal cords and closes the rima glottis during phonation? It is the lateral pterygoid. Important. Closure is done by the lateral pterygoid. Lateral cricoarytenoid. Lateral cricoarytenoid. Okay. Next, a patient presents with a nasal congestion, and upon examination, congestion is present, and upon examination nasal polyps were observed. A coronal CT of the patient was taken as is shown in the given below. Okay, what is the likely diagnosis? Okay, so let's see it. These are the eye. Okay, these are the nasal sinus. It is patent, here is present, but here it is soft tissue is present. So mainly the pathology is in the maxillary sinus. In which sinus? Maxillary sinus. Okay, so answer will be the maxillary sinus. Next, maxillary sinus with the osteometal complex drains, which osteometal complex drain which sinus? Maxillary sinus. We can location of the osteas. Posterior ethmoidal open above. Next is anterior ethmoidal, maxillary, anterior ethmoidal, maxillary, and frontal. And lower opens the nasolacrimal duct in the inferior matus, opening of the nasolacrimal duct. The maxillary sinus drains into which matus? Middle matus. The sphenoid sinus drains into sphenoethmoidal recess. Here, sphenoethmoidal supreme sinus. It is also called as supreme matus. The posterior ethmoidal sinus superior, I have mentioned it. The opening of the maxillary sinus is located in which structure? Opening maxillary sinus is present in the middle matus, which is hiatus seminaris. Okay, where the following is true regarding the esophageal foreign body. Impaction cannot cause mediastinitis. It can cause mediastinitis. It is the wrong question. Where the following is true. Okay, true. More commonly seen in adults. The most common site is impaction of cricopharyngeus. Cricopharyngeus is the narrowest part. So impaction here is the maximum chances. Okay, the most common sign mediastinitis cannot occur as it because it occurs only when perforation is present. It can be the answer, but since C is a better option, so I will go with C. The most common site of esophageal cricopharyngeus, that is the narrowest part. How many constrictions are present? 3 constrictions are present in the esophagus. Which structure causes the second physiological constriction? The first is by the cricopharyngeus. Okay, second and third. Okay, the second and third. Second is by the caused by the arc of aorta on the left. Say arc of aorta like arc of aorta, you can learn arc of aorta. And third is by the diaphragm. Okay, so 3 constrictions we have learned. So you understand 1, 2 and 3. Cricopharyngeus, arc of aorta, and like diaphragm. Okay, DP. Okay, next the investigational choice for suspected esophageal foreign body is X-ray. We do X-ray, AP and lateral view. In AP view, circular ring is present, and in lateral, line is present in esophageal. If there is involved with tracheal obstruction, then in AP line will be present, and then in lateral circular ring will be present. Okay. Next is Rinne's test. Again, Rinne's test we have covered it. We can previously done. Glomus tumor is important tumor. A 50-year-old man present with a hearing loss in the right ear and episodic pulsatile tinnitus. On examination, there was a sorry for the disturbance. Here glomus tumor. A 50-year-old man presents with a 50-year-old man presents with hearing loss in the right ear and episodic pulsatile tinnitus. On examination, there was a mass in the middle ear cavity behind the tympanic membrane. A CT was performed as shown in the given below. Okay, since it's marked in the internal acoustic matter, it is the glomus tumor. It can be glomus tympanicum. It can be glomus jugulaire. Okay. When it is present in jugular bulb, it is glomus jugulare. When it is present in middle ear, it is meatus. Since it is present in the jugular bulb, it is a glomus jugulare tumor. Okay. Let's see the other questions. The most common primary tumor of the middle meatus is glomus tympanicum. Since it is present in middle ear cavity, I have also already mentioned. Glomus jugulare arises from which one? It is a jugular bulb. Jugular paraganglion cell of jugular bulb. The most common symptom of glomus jugulare tumor is pulsatile tinnitus. We have read. Classical otoscopic finding is red pulsating mass behind the tympanic membrane, which is called a rising sun sign, is an important part. The investigation choice for the glomus tumor is MRI with best for soft tissue. Since MRI is done, MRI help in the easy soft tissue evaluation. Okay, so glomus tumor is important. Glomus tumor is very important. Present कर रहे pulsatile tinnitus. Okay. Next, affected of old man, known case of diabetes mellitus. Okay, hypertension present with a nasal bleed. Initially observation such as nasal packing was okay. We have covered it in the previous video that if nasal packing failed, we go with Tespal, sphenopalatine artery. If MCA, then maxillary artery is blocked, external carotid, anterior ethmoidal. Which artery is not blocked? Comment section. Tell. Okay, which artery is not blocked in case of the nasal bleed? Please tell in the comment section. Okay, next, yes ma'am. A 20-year-old patient present with recurrent ear discharge and conductive hearing loss with 30 decibel low. Which of the following is the management of sign? Okay, let's see the options. Okay, total perforation is present. Total perforation, we have to repair it, then we will give laryngoplasty. Repair is called a laryngoplasty. Laryngoplasty is a repair. Modified radical mastectomy is a clearance, atectomy and explorative tympanometry are not wrong option. We will cover the defect with the help of autologous graft. Mostly temporalis fascia is used. Temporalis fascia is used because it is low basal metabolic rate. The surgery done to repair tympanic laryngoplasty. When ossicular reconstruction is done along with tympanic membrane, it is called tympanoplasty. Basically, it is ossicoplasty plus laryngoplasty. Unsafe type CSM associated with cholestoma formation. Most common site is Prusak space. Because retraction pocket are formed there and it leads to formation of cholestoma. Next, this was the figure I was mentioning. Since a hole is mentioned and nothing is visualized, it is a total laryngectomy. We have covered all this in the previous question. Juvenile nasopharyngeal angiofibroma, we have covered it. That it presents with a sign called as Hohmann-Miller sign. Presenting feature. The most common presenting is recurrent epistaxis. Classical radiological sign Hohmann-Miller sign, we have covered it. Sphenopalatine foramen is the originating. Biopsy is contraindicated because it is highly vascular tumor. It can lead to the bleeding. Next is foreign body aspiration. A 2-year child was brought to the ED following choking on a peanut. The child was unresponsive. Since they find unresponsive means unconscious, we will continue the CPR as per to ATLS guidelines. ATLS protocol give chest compression. The most common site for foreign body aspiration is the right main bronchus. Why? Because the right bronchus is more straight as compared to the left bronchus. Okay, the right bronchus is more straight, wide and short as compared to left. Okay, the investigational choice for the suspected airway foreign body is rigid bronchoscopy. The most common foreign body are the peanuts and nuts mentioned in the question. In conscious choking, in a conscious child choking, if the conscious child is there, abdominal thrust, we can give Helmich maneuver. We have discussed it in the previous video, part 1. In an unconscious child, we have to start the compression. And whenever there is unconscious, either whenever you read cardiology, whenever there is unconscious, we will DC cardio version. Okay, synchronized version. Whenever there is child, we give CPR. Okay, these are the common clue words which can help you solve the question. Next, the Welcham's forceps. We have two fractures. We can have the nasal fracture, nasal bone fracture. We can have the septal fracture. Since bone is important and longer, there we will use the Welcham's forceps, and in septal we use Ash forceps. Ash forceps are used. Okay, X-ray was done, and we will present with this. Since we can see the fracture line, we can repair it with Welcham's forceps. The most common nasal fracture, nasal bone. The investigational choice for the nasal bone fracture is X-ray nasal bone. The instrument used for the detection was nasal bone fracture is Welcham forceps. But if it is asked for the septal fractures, then we will go with Ash forceps. We will go with F forceps. Ideally, after how many days? 7 to 10 days after the initial management. Septal hematoma after the nasal trauma should be treated immediately because it can lead to the septal perforation. So immediate repair is required. So septal can be repaired immediately, but nasal repair can be 7 to 10 days, but septal can be should be repaired immediately. So this is all for the ENT. So ENT is complete. Tomorrow we will probably do. So this is all for the ENT. So tomorrow we will probably do ortho or some any 4th year subject. Okay. So kindly like this video.